Go ahead, Dr. Sameer, start off.
Yes, sir. Good evening, everyone. I'll be continuing the venous disorders. So, we had discussed until the physiology and pathophysiology according to, about the varicose veins. So, for the evaluation, we see when the patient comes with varicose veins, we should check we should evaluate his age, as middle-aged people are more prone towards this varicose veins, and female gender, as we had discussed earlier, because of their obstetric history, OCPs, they have a more propensity towards the varicose veins. And strenuous occupations, although there are no proper studies which have been made, but the occupation which have strenuous occupations have a more propensity towards varicose veins. And when patient comes with symptoms of constant dull aching pain, it will point more towards varicose vein, while bursts of pain while walking will denote more towards the deep vein thrombosis. And obviously an ulcer toward at the gaiter area, which is more at the medial malleolus, the part where most of the venous ulcers are there. We have to evaluate accordingly. Previous trauma, surgeries, long-term hospitalization, and the medical histories should be evaluated. Surgeries such as long-term operations should be evaluated. And in the female patients, obstetric history and use of OCP pills should be noted. As of for inspection, the veins which are affected in the varicose veins should be noted. It is either the great saphenous vein, which is the large trunk on the medial side of the leg, or it is the small saphenous vein, which is at the posterior thigh. And for skin, we look for the localized redness. These are some of the manifestations of varicose veins and chronic venous insufficiency. The Phlegmatia albadolens is a milk or white leg, which is caused due to the iliofemoral vein thrombosis, but without an ischemia. And this is more because of the lymphatic obstruction. The pulses may be weak or absent in these patients. And there is a triad of edema, pain, and white blanching of skin, as we see on the right hand image over here. And this slowly can progress to as the venous thrombosis progresses, it will then cause worsening pain, cyanosis from ischemia, and can then further progress to phlegmatia cerulea dolens, which is a painful blue inflammation in which there will be marked swelling and cyanosis, and with obstructive iliofemoral vein thrombosis. And about 50% of this are due to the phlegmatia alba dolens itself. The leg will be very painful, swollen, and frequently it will be covered with this petechial hemorrhage, which we see over here. And then they will, if not treated, will progress to venous gangrene. As of for the tests which
Dr.
we,
Sameer,
uh, sir, sir,
anything else on the inspection you want to see? What is the skin changes? Do you want to mention all that, please? You mentioned skin changes. What skin changes? Is there a list of skin changes?
yes, sir, like the one which we had discussed in CAP classification, the um, lipodermatosclerosis, venous ulcerations,
You mentioned all that
eczematous.
already.
Sorry, sir?
That is all those things are already mentioned.
Yes, sir. In CAP classification, I had mentioned.
Hmm. Okay, good.
Yes. Um, as of for the tests which are done for varicose veins, there is this Brody Tendelmark test in which we check for the SF valve and other perforator incompetence. What we do in it is first the veins are milked away and in supine position, and patient is asked to stand up quickly, and then there is a tourniquet which is already placed at the SL valve, and then if there is a SF valve incompetence, there will be vein filling which is seen, and if there is a 1 minute delay, it denotes perforator incompetence. So if both are there, it suggests SF valve incompetence with perforator incompetence. The same thing is done on multiple tourniquet test, wherein tourniquets are placed at different levels of perforators below knee, above knee, and then the before this the veins are all milked away, and then the patient is made to stand, and if there is a incompetent valve, the vein below the incompetent valve will fill, denoting the incompetence of the same. Further, we have the Perthes and modified Perthes test. In Perthes test, the patient is asked to walk with a wrapped elastic bandage, and there will be severe crampy pain in case of deep vein thrombosis. Wherein in modified Perthes test, the tourniquet is tied around the upper part of thigh, and patient is asked to walk. If there is a normal venous physiology, the veins will shrink, wherein because of the varicose veins, it will be more dilated and tortuous. For squash test, we check the impulse on the lower end of the um, uh, perforatory incompetence, and we can feel the pulse. We can feel the when we tap on the long saphenous vein on the lower part of the saphenous opening, we can feel the impulse. On for as for the Pratt's test, we first give a compression bandage to the patient, and then after milking the veins, and then slowly we remove the compression bandage, and all the perforator blowouts can be seen one by one in Pratt's test. For the Morrissey cuff test, it is usually seen in a long-standing venous in incompetence. We can feel the cuff impulse on the SF1. Now for the radiology, as we know, the optimal investigation for the chronic venous insufficiency is a duplex scan, wherein the primary objective is to find the reflux in deep and superficial segments of veins, give the plan of management, detect thrombus. Uh, According to the vascular consensus and the radiological guidelines, this is what radiologists usually perform. They check the common femoral vein first, then they go to the upper femoral vein, then three will be the lower femoral vein, then the popliteal vein, then they come back to the SF junction where they see the Mickey Mouse sign, and from there they go up to the great saphenous vein, the mid thigh segment, the lower thigh segment, and then the calf segment. Further, in the posterior thigh, they will check the communication of the small saphenous vein to great saphenous vein, which is the Guykomanis vein, and then check on the small saphenous vein, the posterior thigh segments. So in this, what they do is they perform the Valsalva maneuver, as denoted in this example, where I have they mentioned the great saphenous vein. The A, B, C, D are the performed Valsalva maneuvers, and the radiologist perform the Valsalva maneuver on these parts of the great saphenous vein on the mid thigh, distal thigh, and upper calf. And as we can see on the spectral Doppler in image E, where there is a incompetence denoted by this backflow of the vein during the Valsalva. As I said earlier, the radiologist can also give a roadmap of treatment. As we can see over here, the great saphenous vein is almost 1 centimeter. and there is a 3 seconds of reflux, which we can see in the great saphenous vein. So if this patient goes for laser ablation, then it will mostly be a failure because of such a big reflux. As of for MR venography, this is actually preserved for pelvic congestion syndrome and in patients where there is a complex anatomy, and it will give a more better roadmap for pre-op planning for the patients. Sir, anything in the radiological investigation?
What is pelvic compression syndrome?
Sir, in pelvic compression syndrome, the two venous systems are involved, sir, which is the ovarian and internal iliac veins. And because of the incompetence in these veins, there will be reflux and varices in internal iliac vein tributaries and the lower extremity. So if we don't find over like a proper varicose vein, chronic venous deficiency in the lower veins, we can then see the ovarian veins and the internal vein tributary. And because of this incompetence, there will be, but the patients will have multitude of symptoms like abdominal pain, and there can be also this iliac vein compression, nutcracker syndrome. All those things can be there. If we don't find a proper lower limb pathology in duplex, we can go for MR venography for this pelvic congestion syndrome.
Where do you get the venous ulcer?
Sir,
Venous ulcer, which part of the leg?
in the gaiter area, sir, on the more on the medial malleolus.
Why it is the you get the
Because
ulcer there?
the oxygen tension at this area is very low, sir.
Why it is low? They are not in the toes.
Because already because the gravity, sir, there is a
Toe is the most disturbed part, no?
sir, yes, sir.
Hmm.
So to reach over there, they continue, sir.
Why the answer the why are you worried? Why you develop venous ulcer in the gaiter area? Why it is called gaiter area?
Sir, name, why the name is given, I specifically don't know, sir. But it is the region around the ankle and calf where the oxygen tension is low, and we'll get more of hyperpigmentation and discoloration of skin, lipodermatosclerosis all over there, sir.
Why? Why not on the dorsum of the foot?
Dr. Samir, if you know the anatomy, then you can answer Sir's question.
Sir, because the
To give
oxygen
a,
tension.
to give you a clue, what is the relation between the superficial vein system in the foot and what is the difference in the leg? If you know that, then Sir's question can be easily answered.
Don't know, read and then put it on the WhatsApp.
Yes, sir. Yes. Okay.
Uh,
Ravi Shankar is
Dr.
not there. Ravi Shankar is not there.
Anybody,
Just answer.
anybody else can answer also.
Yeah,
Not
anybody
only
can.
me.
So
Nobody
it's the
knows all
medial
of
end of the dorsal venous arch. Uh, basically that is the area where the dorsal venous arch ascends up. So uh, that is the reason, sir.
Sir.
So basically, in the foot, there are no valves between the superficial and the deep systems. So there is easy pressure-related flow transmission between both the systems. But once you come to the leg, you have the clear differentiation where the direction of flow is only from superficial to the deep, and of course you have the incompetent perforators which helps to push it back. So and the number of perforators are the highest in the gaiter area. So that is why we get ulcer most common in the gaiter area. Because the number of perforators are higher, only the superficial venous pressure is highest in that region.
Yes.
Is there anything else, sir?
No,
Dr.
no,
Manu?
that's the main reason.
Yes, sir.
Okay, Samir.
Dr.
More.
Sameer, one more. Dr. Sameer, how do
Yes,
you
sir.
class? You said in Doppler, you can see that reflex and all right in the junction.
Yes, sir.
Is there any grading of the reflex?
So the standard
Hmm.
grading for superficial veins are should be more than 0.5 seconds, and for deep veins
Hmm.
it is more than 1
Hmm.
second.
Yeah, that is there. To tell it has a pathological reflex. But
Yes,
how
sir.
many grades of reflex are there?
And the normal, moderate, and significant, that one, sir.
No. That is all time pass report. Mild, moderate, significant, and all is. If a report comes like that, that means that report is invalid in my opinion. The grade has to be put as grade 1, 2, 3, or 4. Grade 1 means it is 0.5 to 1 second. Grade 2 is 1 to 2 seconds. 3 is 2 to 3 seconds. And grade 4 is more than 3 seconds. Okay.
Okay. Yes.
Anything else you want to look for? Apart from the reflex, you mentioned thrombus. You mentioned junction evaluation, deep vein evaluation, yes. Anything else you want
Anatomical.
to see? Okay, anatomical variations, yes. Anything else?
Uh,
Does the size of the vein matter?
yes, sir.
Hmm. The size of the GSV or the SSV does matter.
Mm.
So sometimes you may have um normal reflex without a normal junction without any reflex, but you can still have a dilated GSV. Why is that?
Don't know, sir.
Many time if you notice that patients will have a normal junction, but a mid thigh perforator can become so big that it can mimic a junction. So these kind of patients will have a dilated GSV
Sir,
and
because of
significant amount of lower varicosities, but a normal junction. Okay.
Sir, I'm not understanding, sir. Can you explain again, sir? Like,
No, the SFJ will be normal without any
okay,
reflex,
okay, sir.
but there'll be the mid thigh perforator
Yes, sir.
in many patients are significantly affected, incompetent, that
Oh,
it mimics the junction actually. So you have
okay,
many
sir.
patients who have a dilated GSV from the mid thigh downwards
Okay,
and significant varicose veins in the legs.
okay,
So just because junction is normal and we cannot tell them, okay, this patient doesn't require open surgery or laser like that. You have to see what is the clinical picture they're coming with.
okay, sir.
What is May-Turner syndrome? You told about MR venography, no? One is pelvic congestion syndrome, yes. What else to look for is May-Turner syndrome. What is May-Turner syndrome? Why is it important?
sir, it is the iliocaval, this one, the compression syndrome, wherein the iliocaval unit is compressed, sir.
Compressed by what? See, basically, it's a natural crossing. All of us have it. See, the proximal part of the left common iliac vein is compressed by the right common iliac artery against the bony spine. This crossing all of us have. Somebody put a short note on Maithaner and put it in the group. So this crossing, if it is significant, the compression can cause long-term injury to the vein. Okay, and so if the proximal common iliac vein is occluded or significantly stenosed, that means the patient will have a significant deep vein reflux, and that can show as a varicose vein in the leg. So for patients who are having significant limb swelling, significant venous ulcer, in spite of not responding to the standard compression therapy or even after superficial vein treatment and all that, you have to rule out this Maithaner syndrome, which is very, very, very common. Okay. Go ahead, Dr. Sameer.
So, as of for the chronic vein insufficiency, these are the current therapeutical guidelines and with levels of evidence as mentioned. Compression therapy is the initial therapeutical thing which we offer to the patient. Uh, For initial life, the patient should be counseled for lifestyle management, weight reduction, exercise, and the primary objective of non-operative management is while we give the leg elevation to the patient about 30 degrees above the heart level, and compression therapy with gradient elastic stockings. So these are the compression classes which are and with the recommendation of use light, medium, strong, and high. Medium, strong, and high are the ones which we commonly prefer for venous efficiency, chronic venous efficiency, and post-op prophylaxis after the procedures have been done. And herein the finesse is the fit of the compression stockings which are used. And A, B, C, and D are the differentiated compression zones of the leg, wherein 100% compression over here in the distal this one gaiter area, 70% in the mid thigh over the and 50% over the mid thigh, and calf will be around 40%. So these are the different types of compression devices which are used now. Most commonly used are the multi-component bandages, wherein there will be a elastic and an inelastic component. Their advantage is that because of the high working pressure, they are well tolerated during rest also, while they are not reusable and they can be bulky and warm. There are also these hybrid pumps which are adaptive compression therapy. Uh, the patient can apply them self application. They can have showers with this dressing also, but and they won't need a daily this one management of skin and all this thing. The inelastic one, which are the older used one, the zinc paste, they are messy and they have a high, but they have used to have a high working pressure and they were well tolerated. But because of the paste and everything, it is very messy. I will be coming to the bandages more in venous ulcers. So
Dr.
what
Sameer,
does, sir?
the compression stockings,
Yes, sir.
the grades which you have put, is that the commonly used system, or what do we use when you're, let's say you're writing a prescription for a stockings for a patient? What do you mention? I'm sure you would have written many. What do you mention in that?
Below knee.
Yes, we mentioned below knee or above knee, and then Some class you will write. Something called class 1, class 2, class 3, right?
Yes, sir. The
Oh.
one which is like,
Hmm.
sir, these are the classes only.
What is class? How much does class 1 give pressure? How much class 2 gives pressure? How much class 3 gives pressure? That is what is very
Class 1
commonly
is 15 to
available,
21,
no?
sir.
Hmm.
Class 2 is this one, sir, the medium strong one, and high will be this one. The strong one, the class 3, which is uh 35 to
Hmm.
45, sir.
Okay. I'm not aware of this kind of classification for the stocking. The simplest one which I am aware of is class 1, 2, 3, and that is what is being most commonly followed. It's like that only, no, sir? Isn't sir?
Yes, sir.
So, this modality I have not used before, light, medium, strong, high, and all.
Correct.
So, class 1,
I'm
2,
also
3
not.
is what?
Class 1 to
Yes,
3 is what I also am aware of. I don't know where Sameer has
yes,
taken this from.
yeah. So, maybe somewhere you can just put that also in the group later.
Yes, sir.
Where did you take this from?
Sir, this was I'll put the journal also, sir, that study.
Oh, no. Is it a
Sir,
novel thing or is it the
no,
generalized
no,
thing?
sir, no, sir. I,
What?
it is not a novel thing, sir, but I'll put the, yes, sir, the link
No,
to it
because we
also.
are not aware of this. Srikanth sir, ನಿಮ್ಗ್ ಗೊತ್ತಾ?
I know only class 1 to class 2, class 3.
Yes, sir.
Okay, so we put it up. We'll see.
Yes, sir.
Sir, what is your opinion of this wraps which you get, vein flux wrap or like that, things like that?
Sir,
If the patients
vein
cannot
flux,
tolerate, if the
yes, sir.
patients cannot tolerate the stocking, some people
Yes,
like
sir.
they don't, they get developed lips and all that.
Yes, sir.
They
Yes,
won't
sir.
be able to put it up and all those things. So, is there any role for those wraps kind of a thing?
Yes, sir. Definitely, sir. Because nowadays for elderly population, I'm directly giving wrap only because none of
Okay,
them are able to tolerate a stocking.
correct,
And
correct.
and in the wrap also, sir, this vein flux wrap was what very recently launched.
Uh,
It's like a good quality crib bandage technically. The material
correct,
is good.
correct.
There's a good Velcro and
Reusability.
very much reusable, washable and all. But apart from that, there's other wraps also available, sir.
Okay,
Which has two separate components. Again, problem with vein flux is again it is a little bulky once you apply it also.
okay.
The other wraps you have two. It comes as two separate pieces. One for the foot, a separate wrap, and one for the calf region, a separate wrap. And that
Oh,
also
okay,
has Velcro and it's quite washable and easy to use. And especially for
okay,
elderly, if they want to go to the washroom immediately, they can just take it out and walk, come back, and they can put it themselves.
okay,
So it is available, but only problem the cost is slightly high, sir. The vein
okay.
flux, foot and leg for one leg itself is almost some 10,000 or something.
Oh, okay. So it is
But
more costlier than stocking.
yes, sir, more costlier than stocking. But I feel it's for elderly people that is more better, sir.
Any brands like this thing?
So the venous and itself have it, and even the Sigvaris people have it, sir.
Okay, okay,
Both Sigvaris and venous are available.
okay.
Sir, do
And
wraps also have classes, sir? Like grades of compression or
no, it only has I think if I remember below knee and above knee, the length of the wrap changes.
Yes, sir. So the company claims that they will give a class 2 kind of compression,
Correct.
but I feel in reality we can take it like a class 1 compression, sir.
Last one. Okay.
Yeah.
And is it mandatory to always put it above knee or below knee is sufficient? Because most of
Sir,
them will not tolerate above
yes.
knee.
Yeah, below knee is more than enough, sir. More than enough.
Okay.
Above knee, only post surgical for the initial short period, I give it, sir.
Okay.
After that, I also switch it off to below knee if at all patient requires a prolonged compression.
Okay.
But for in all the patients who are in conservative management, below knee is more than enough, sir.
Okay.
The frequent question patients ask us is, sir, I have veins visible in the thigh also. Why are not
Correct,
giving the above knee? I explained to them that whatever effect of the vein will come below knee only. So why you want to be more uncomfortable? And most of them are okay with that, sir.
correct, correct. Yes, sir. Move on, Samir. If no questions.
So as discussed now, there are the complications of skin blisters, necrosis, and peripheral nerve injury. So what the stockings do it? This is a picture of the vein without the chronic venous deficiency without stock compression therapy. There will be pain, edema, inflammation, skin changes, and obviously ulceration due to the venous reflux, blood stasis, and hypertension, which I've studied earlier. After these stockings, there will be improved microcirculation, cutaneous oxygenation, increased lymphatic flow. There will be and reduced venous reflex because of the augmentation of the compression itself, and reduced edema and inflammation with reduced risk of thromboembolism. So, coming to the veno-active drugs or the pharmacotherapy, which is uh, for the chronic venous deficiency, as of now, the micronized purified flavonoid fraction, which are the veno-active drugs, which have a flavonoid derivative, are the one which have the largest evidence base for safety and long-term use, and they have proven efficacy in suppressing the leukocyte endothelial interaction, and also they give treatment for they are used in treatment for venous edema and reducing the venous pain. Patients who have taken the MPFF have a higher quality of life, and the duration of this MPFF vary from up to 2 months for initial stages, and with adjunct to the procedures which patients undergo, they can be given up to 6 months for trophic skin changes and other after the procedure is done. Saponins and these ginkgo biloba extract, there have been no study. Most of the study are more in the European part of this horse chestnut seed extract, where they've seen some promising results. Coming to the
Sir,
sclerosis.
your
Sir,
word on drugs, medication, sir. Sir.
Sir, like Dr. Sameer said, only the flavonoids are useful, sir. All other medications are, in my opinion, not of great value. But flavonoids are very good, sir.
No,
Daflon was the classic.
yeah, when will you give and how long can you give and this thing?
Yes,
Like, is
yes.
it only given when there is inflammation or you will give it routinely?
No, sir. Patient doesn't have any symptoms. I don't give it at all, sir.
Okay.
But if patient has that crampy pain, dull aching pain, or especially over the distended veins in the end of the day, they have pain and all. That time I find it very helpful, sir. Otherwise, just minor veins visible, all this spiders, reticulars, or even very small varicose veins, or a patient comes to show just because somebody told them and they have absolutely no symptoms. That time I don't put them on Daplan and all, sir.
Okay, and if you
Uh,
put them on, what is the dose and duration, sir?
Sir, 500 mg twice a day or 1 gram once a day, both are equal. Only thing the 1 gram tablet is slightly big in size also.
Okay.
Duration, 3 months is what I put, sir, usually.
Okay.
And especially post therapy, post laser and all, definitely I put for 3 months. If the patient has a venous ulcer, I keep them on Flavonol till the ulcer heals. Whether it is 5 months or 6 months like that, I keep them on that till the ulcer heals, sir.
So, and that will be 1 gram OD dose or 500 mg BD
Yes,
dose.
sir. BD dose. Yes, sir. Yes, sir.
Okay.
The trade name available?
Daflon.
Sir,
Oh, Daflon.
Daflon. Yes. Sir, the new ones that Aldosmin, all that available, sir. Venoflav, Aldosmin and all, Indian brands have come, sir. They are also equally good, sir. I've tried both of them, Venoflav and Aldosmin. Both are as good as Daflon, sir.
Okay. And same composition.
Same composition, yes, sir.
Okay.
Aldosterone, I feel, is more easily available nowadays than Venoflav,
Hmm.
and its cost is also lesser compared to
Okay.
Daflam.
Okay, sir.
Yes, sir.
You continue, sir.
Yeah.
So, coming to the procedures, the sclerotherapy is a versatile procedure which, with the primary objective to transmute the vein into a continuous strand of connective tissue. It can target intradermal, subcutaneous, and transfacial veins. The contraindications, so absolute are hypersensitivity to the sclerotherapy agent, acute venous thromboembolism, and
Sameer,
localized infection. Sir,
before going in for contraindication, when will you do for what condition you do sclerotherapy? Will you do it for all, or will you do it for one specific condition, specific like problems?
Tell me the indications.
Come on, Sameer, you can't stay silent. You know or you don't know?
sir, when we see varicose veins, the CAP, in the CAP classification where you see the reticular pattern and telangiectasia, and there is a name, this one enlarged perforator and tributary veins. There we go for sclerotherapy.
Only that much? Anybody else? Nikita? Praveen? And us?
Sir, when there is residual varicose veins or recurrent varicose veins.
So it can also be used for the hemorrhoids and other areas.
No. We are not talking
Talk
about
about
hemorrhoids.
varicose
Forget
veins.
hemorrhoids. Varicose veins. Yeah, I'm talking about indications for sclerotherapy in varicose vein disease. For what you will use.
Also for perforator veins, sir.
What do you mean by perforator veins?
In case of minor tributaries,
Okay.
it can be used to seal off the perforators.
Sir?
Apart from, yes,
The sclerotherapy for most commonly, along with the laser or additional to open, is the most common time we are using it, at least in the Indian scenario. But in abroad, it is being used for more of a cosmetic purpose for class 1, 2, and 3 veins, very commonly. In our context, it is more of along with the primary therapy or for recurrences, or even sometimes patient with a long-standing venous ulcer. Already we've treated the GSV component and all. Sometimes they have a new vein going towards the venous ulcer, which is not allowing the ulcer to heal. So that time again we can give a focused sclerotherapy. Apart from that, class 1, 2, 3, I mean CAP 1, 2, 3 is only cosmetic, sir.
And which one you will use? Agent Cetrol.
Cetrol only available, sir. Polidocanol is off the market now, not available in India now.
Oh, okay.
Polidocanol, it is less inflammatory than Cetrol, sir.
Yes.
So Polidocanol, if available, definitely I would use Polidocanol. But nowadays it's not available, and second issue is the cost also, sir. Cetrol is very
Hmm.
cheap.
Correct.
Polidocanol is costly.
Okay. And is there any like dose restriction or anything, or and you make it into a foam or you inject directly? Foam
So
is
always,
better, I suppose.
always foam, sir. Always foam, sir. Make it into a foam always. And one session, especially when we're doing this bilateral varicose veins and all, we see to that we don't cross 4 ml of cetrol, sir.
Okay. And it has to be diluted or
Sir, dilution to thought process is there. Some people do like 1 ml cetrol to 4 ml air.
okay.
Some people take 1 ml cetrol, 4 ml air plus 5 ml saline.
Okay.
Some people take 1 ml cetrol and 9 ml air.
Okay.
I generally prefer to use 1 ml cetrol with 9 ml air, sir.
Okay. So
It's
that is the
I
general recommendation.
yes, sir, yes, sir. And that Tessari method we have to use. Connect
Okay.
it with a three-way stopcock and minimum 20 times up and down. That will
Push
give
and
the
yeah.
correct foam size, and the stability of the micro bubble is also better if we do it minimum of 20 times.
Okay.
One thing that recently what which has come is the type of the syringe which should be used, sir. Actually, the
Okay.
syringes with that rubber or silicone inside, no, sir. They say that
Okay.
that breaks down the bubble surface faster than a syringe without the uh, silicone or the rubber. The BD company syringes which come, sir, they don't have
Okay.
that rubber or the thing.
Okay.
So
Okay.
recently, there in one of the vascular forums, there was a comparison between even the type of syringe, whether it will make a
Oh.
difference. And
Okay.
this is what came up, sir. You should ideally use a syringe without that rubber or that a silicone stopper.
Okay.
But most of the time, we all the cheap syringes which we get has that. And
Okay.
the only one which I have noticed is the BD company syringe doesn't have that rubber stopper.
Okay. Okay. Yes, Samir. Any doubts regarding sclerotherapy? Okay, Samir, go on. Samir,
So the yes, sir. So the agents which are used are either liquid versus foam. Foam is a uh, much
see,
better.
these are not the agents, man. That is a type of sclerotherapy,
I,
how you inject. Agents are, as we were discussing, it is cetrol or polydecanol, polydocanol.
Okay.
Hmm. Where did you
So
get this? There are no references to any of your slides.
uh,
What is that success rate?
yes, sir. So with foam therapy, there is a success rate of about 85 to 90%. And this is how the tertiary method is it is either 1 to 3, 1 to 4, or 1 to 5, and with a three-way valve repeated 20 times, we do the tertiary method to produce the foam. And then the desired vein, which is um, targeted, is then punctured with the scalp, this butterfly vein, butterfly
Calpine,
needle. And
calpine set.
yes, sir. And then the backflow is checked. Then the foam is introduced, and venospasm is noted. After the
Samir, basic
sir,
question. Samir, basic question. You inject into the vein or you inject into the periphery? You said backflow is checked, no?
sir,
What you want to check in that?
we are not going into the
Huh?
sir,
You
into
know,
the vein only, sir.
no, sir? Into the vein only, no?
yes, sir, into the vein only, sir.
Yeah. So you have to make sure that you are in the vein, not for the periphery, because it can sometimes cause extensive inflammation.
Yeah.
Correct, no, sir?
Yes, sir. Yes, sir. Extravasation is a very bad thing, and the patient would complain about the sclerotherapy rather than the laser, sir.
Correct.
After the therapy, the again the
Dr. Samir,
same, sir.
you want to empty the vein when you inject the sclero, or you want blood to be present in the vein when you inject sclero?
So veins are milked before.
Yeah, that's correct. Why?
Yes, sir.
How do you milk it?
Sir, the same way we do the test, no, sir. We raise the leg, sir, for milking the veins.
Yeah, correct only.
Correct.
Just tell
So why
what
are
you're telling
you
is correct.
hesitating? Hmm. Why is it? Why it has to be done?
Sir, it can go to other like
Can go to other leg.
Other
other
leg.
tribute. No, sir, the tributaries.
So
See that
agent acts on
inflammatory.
the wall, sir.
Yes, the foam has to act on the wall first thing, so that surface area contact is more if you have emptied the vein of as much as blood as possible. Second thing, the inflammatory component is very high when you have blood there. So if you have a very big superficial vein and you've injected without emptying, in the post-procedure patient will have a very significant superficial vein thrombophlebitis. So always empty the vein and then inject.
So do you have to compress it at the top or no? Just empty it and immediately bring it down and inject
Yes, sir. Yes, sir. When it is elevated only, I inject off, sir.
in the elevated position. Okay.
Yes, sir. Yes, sir.
Post therapy, we check for the same reflux and the morphology of the vein. If it is how much of the vein is occluded, how much of the vein is patent, and how much the reflux, if is it successful or not. We check after the procedure. Um, as of for endovenous and RFA technique, the endovenous technique was pioneered by Dr. Carlos Bohn in 1999. It is usually performed as a outpatient procedure. Um, the method is it entails the insertion of laser fiber into the targeted vein, and the laser fiber will emit laser energy to induce thermal injury within the vessel, and this will cause vein constriction, thrombosis, and development of venous fibrosis. In EVLA, the laser wavelengths which are used are either 1470 or 1940 nanometer, and they have a 92% success rate. There are studies which have proved that 1940 nm diode laser was associated with lower median stays in hospital with lower pain score, and because of the lower power and linear endovenous energy which was used for this laser. So both techniques have a similar method. We will place the patient in prone reverse tendon position, and monitors will be there with EKG and pulse oximetry. Then we'll inject the local anesthesia, and we'll assess the vein with the needle, and then after removing the needle we'll replace it with a dilator. The dilator will dilate the vein and will advance up to
You should put a small video, man. It's difficult to follow otherwise.
oh, okay.
Okay, explain.
Yes, sir. Dilator up to the SF junction, and then the dilator, the guide wire which was there is replaced with the laser fiber. The laser fiber is then uh, laser fiber is introduced, and then we give the tumescent anesthesia. Tumescent anesthesia is where we give large amount of anesthesia with um, bicarbonate and adrenaline. This anesthesia will insulate the surrounding tissue, nerves, and deep vessel from the heat injury, and thereby increasing and it will also compress the targeting vein, and it will ensure that the targeted vein is there is thermal injury by the laser. After the laser is heat applied, it will be withdrawn at 2 to 4 per second, and the whole the vein is then the procedure is done.
So you inject tumescent anesthesia at the SF junction.
Yes, sir, to protect the uh,
Okay.
female
One,
vein.
how do you make sure that it is at the SF junction?
So these are all done at ultrasound guidance.
Doctor. Okay. And then second question, basic question. You said you have to pass the guide wire. What if the guide wire doesn't move beyond a certain length? What will you do then?
Uh,
Fast. You can't just keep on like silent, being silent. You know, you don't know.
Sir, we can give us this one skin incision and then guide it.
How will you give a skin
So we
incision
found
and guide it?
another tributary.
There is disturbance. Hello.
So we
Who was
find
that,
another,
Nikita?
and yes, sir.
Yeah.
We find another tributary which is contributing to the GSV and find a way through that into the GSV beyond that
Shravan sir?
resistance point.
Sir, we can always try to manipulate the guide wire. The guide wire which comes with most of the sets is a very non pliable guide wire. We can take a thermo-hydrophilic guide wire, and because it's a hydrophilic guide wire, it even through very tortuous veins and even sometimes a post-phlebitic narrow vein, it can go through. That is one method.
Okay.
Sometimes we use some of the angioplasty methods also. We take a support catheter, and the catheter will have angled tips. So that will help us to rotate the area where we want to, and then under ultrasound guidance, we can left hand in the ultrasound, right hand we rotate the catheter, and we can tell the assistant to push the guide wire. That is one thing. But fortunately, nowadays we have the fiber, which is the front is very smooth, sir. So it is very
Okay.
easily going through. The older fibers, the front was very sharp in nature. So
Okay.
we used to
Okay.
end up puncturing the vein.
Puncturing the vein. Yeah.
Yes, sir. So now the newer fibers have a very smooth forward tip. So it's easily moving across the even narrow segments sometimes, sir.
Okay. But is there any
And
role, as Nikita was telling, but doing
yes, sir.
multiple punctures and
Yes, sir.
entering through
We
different?
do, sir. We do that
Okay.
sometimes, sir. We do that. Double two times we'll put sheath, and half we'll do through two different accesses.
Okay. Any other tips, sir? Or any other
Uh,
thing which Sameer missed?
so even sometimes after taking the access, uh, like our artery goes into spasm, it will be very surprisingly many a time we have seen the veins also go into spasm, sir.
Okay.
Especially in the ladies, we have seen that. So through anyway we have a sheath there. We can always
Okay.
inject saline, try to dilate the vein a bit, or we can give very small dose of very much diluted NTG gently into the vein, and it will help to expand the vein immediately, sir.
Okay.
And even in this picture, sir, one thing I would like to show that the access is in the gaiter area. Like how we don't do stripping beyond the below segment, sir, so that the saphenous nerve doesn't get affected. The
Correct.
same thing applies for laser also, sir.
Okay.
The picture in the right, it is shown the perfect location of where we take the access. That below segment is where we take the ideal access. The picture in the left, they've taken quite a low access, but we shouldn't burn it till that area, sir. We will end up burning the saphenous nerve also.
That's all.
Then finally to the surgical stripping, which was once the standard of care. Now it is only reserved for elective cases because of the uh, prevalence of saphenous nerve injury, which is according to the
No, no.
studies.
Sameer, what do
Uh,
you mean by only reserved for elective cases? All of these are elective cases only, no?
It's all surgeon's preference,
Not like that. What do you mean by elective cases?
not an emergency.
sir,
You mean something else, right?
even after failure of these procedures.
What is that? Even after failure of procedure.
As Dr. Sameer, I think the correct word would be, instead of elective, would be selective.
Correct. So, what are the indications for surgical stripping? Current recommendation.
And now there are no, as if as we saw in the recommended therapies, sir, according to the levels of evidence, there is no uh, set recommendation for surgical stripping itself.
Shravan sir, is it right?
Sir,
There is
the
no
most common is
recommendation at all.
no. It is size of the vein matters, sir. Uh, Even though there's a lot of data showing that for 18 mm, 20 mm veins also we can do. In reality, sir, up to 15 mm we can do, sir. 12 to 15 mm is acceptable.
Laser.
And,
Laser. You
yes,
mean
sir,
laser?
laser we can do
Yeah.
laser. Anything beyond that, still open only is the best, sir. No doubt. And
Okay.
if
That
especially
is
if you have
one.
this Safina varix and all is there, no, sir. Quite bulged out junction and all. That
Yes.
definitely open only, sir. Laser has absolutely no role in those kind of cases, sir.
Okay.
That, and of course
And
recurrence cases.
recurrence, yeah.
Then phlebectomy, of course, always has a role, sir. Even now with the laser, I combine lot of phlebectomy, especially with big bunches if it is there.
Okay.
But stripping, I would say these two things only, sir. That's saphenous blowout and size of the vein.
Okay. And recurrence.
And recurrence, yes, sir.
And in recurrence, can you again redo laser or you will always prefer stripping?
Sir, recurrence, I screen the patient myself, sir, in recurrent cases. If the recurrence is because of a duplicated GSV, or you have a very large tributary which has become as big as the GSV, then we can do laser, sir. Otherwise,
Okay.
phlebectomy plus sclerotherapy should be enough, sir.
Okay. Assume.
Yes.
So, see, whenever you put up
Sir,
something, you should know the indications. You can't just copy paste some thing from there and come here and tell us, because you should be knowing what it is. Yeah, Nikita, you wanted to ask.
So in case of duplication of GSV,
Hmm.
we would be knowing it in the for the first time, no sir, even before the recurrence. Would the
Yes,
management
yes.
be different in the primary treatment only, sir? Like
No, I will do laser of both in the same setting.
in the same.
Double,
Okay, sir.
double sheet, yes. Double sheet into each of the GSV, finish off
Okay, sir.
laser of each in the same setting. Many a time we have this anterolateral thigh vein also very big as the GSV also. So that also we take double access, one in the upper thigh lateral aspect into the anterolateral thigh vein and other into the GSV.
Okay, sir.
Go, Dr. Sumit.
Yes.
Oh, you have not mentioned about Trendelenburg operation.
Yeah, explain the steps, no?
Yes, sir.
Sikandar is asking the steps. Explain the steps.
Only you have mentioned surgical stripping. What about Trendelenburg?
Sir, for this surgical stripping, we give a 1 centimeter incision below the knee and then find the tributary of, like, for example, if it is a great saphenous vein, mostly the radiologist will be asked to mark it, and then the tortuous segment is then lifted up. The stripper is passed through the vein up till the SF junction, and then another groin incision is given, and then the stripper is then retrieved. I'll show it in the video, sir.
You can tell in exam you'll be asked. You also have one practical thing where you're supposed to choose a operative procedure and tell the steps, right?
Sir.
Okay, tell.
Mhm.
Go on, Sameer.
Yes, sir. One sec. Validation.
Already 10:05.
What happened, Dr. Samir?
One second, sir. This video.
Just play it. No, you're not. Don't slide it. Just play it. Yeah.
So they took a segment of the great saphenous vein in the distal thigh, and then they've
Distal thigh. What procedure is this?
mid thigh, sir.
What do you think?
Huh?
Sir,
What is it you're showing? What procedure is it?
stripling, sir. Stripping.
Stripping. You're showing in the leg. No, this is not mid thigh. This is below knee, right? What you're showing?
Passing from below upwards.
You're telling you're going into the distal thigh. You said, then you said mid thigh.
This is groin, huh?
Speak. This is groin.
Yes, sir.
Yes,
Speak up.
yes, sir. So then from the tributary they pass the stripper from until the SF junction. Then over here they will
Why do you pass it from below upwards? Why not from above downwards?
because then the veins will be the valves will be we can break it, sir, once it
Valves are.
the
If you slip, the valves will be broken. Is that the reason?
yes,
Anybody
sir.
else? Shravan sir, is it more because to prevent injury to the nerve, or what is it? You think is it right or
Sir, I was always been taught to pass from down to up only. Because
uh,
along the valves it will go off up. So that's what I have been practicing in general surgery time and after becoming master
no? But
surgeon
the
also.
reason they say, is to prevent injury to sural that nerve.
Sir.
Is that right, or is it just to make the
I've
valve?
yes, sir, I've always felt half the examiners are for top to bottom, some of them from bottom to top.
Uh,
So I guess that day whoever comes.
okay, because in I think in the das and all that, the reason given is to keep it like that because to prevent injury. That is what I think. Am I right,
Oh,
Nitya? Tanya?
Yes, sir. But even when we were in BMC, some units, most of the units, they pass it from above downwards, sir. And sometimes if they can't feel the passage, like if they can't feel the tip of the mare stripper, then they will go somewhere along the course and then they will make above the knee
Multiple
also they
cuts.
will
separate
strip it.
resistance.
Multiple cuts. Yes, sir.
Yeah.
Yeah, that is there. That is there. So actual recommendation is below downward, below from below upwards.
Yes,
Is
sir.
it right? Shravan sir, that is the recommendation, no standard recommendation.
Yes, sir. Yes, sir.
Yeah. Okay. Go on, Samir.
Then after isolating the great saphenous vein, we have to make sure that we are ligating all the tributaries, which are the anterior posterior circumflex vein of thigh, the um, posterior and anterior accessory vein of the thigh, and then once it is isolated, we then pass the uh, mm, this additional thing is because of the tortuous vein they have done. Then after the procedure, compression bandage is applied for the patient.
Shravan sir, is the current recommendation still that you have to remove all the tributaries, or is it like you go below the tributaries and strip it? If
And
at all, if you do,
remove all tributaries, sir.
remove all tributaries. Okay.
Yes, sir. Yes, sir.
Move on. Sir, any tips and any other thing which you want to tell here?
No, sir. Nothing else specific from open
Okay.
surgical points, sir. Go on, Dr. Sameer.
Yes, sir. For future, for future directions for chronic venous diseases, there are
Sir,
now
one, one,
researchers.
one, 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 1 minute. I had one question. So when you do stripping, what about that perforator ligation? You do multiple stab there and take it out, or how is it?
Yes, sir. I always do staph infective medicine, sir.
Okay. So you would have marked it pre-operatively only, and then you do that at that point.
No, sir. Whichever bunch is more prominent, I put a nick there, sir.
Okay. So you don't mark the perforators
No, sir.
separately
No,
and
sir.
target them. So you just
No,
strip
sir.
the
No, sir.
veins and only the dilated parts you take out.
Yes, sir. Yes, sir.
So there is no role for specifically marking perforators, because that was also there, that concept that you have to take out the perforators also by marking them separately.
Radiologically, it's easy, sir. But if
Uh,
the small incision which we put,
okay.
it's very difficult to go and correctly get that perforator and ligate it, sir.
Okay. So it's just stripping is enough.
Yes, sir. Stripping and that superficial punches, when you do the phlebectomy itself, if you have neatly ligated the branches also, it is enough,
Hmm.
sir.
Okay. Samir, go on.
Yes, sir. For future directions of chronic venous insufficiency, now there are studies more directed towards the individual pathogenesis, which is epigenetics, so that we can understand better about the treatment. And also there are this new ultrasound technology, which is um, the one which we use in mm, hepatic lesions. They are also used in varicose veins. Now there are studies which have promising results about the exact they give a better roadmap for this treatment. Also tissue engineering for valve replacement and optimizing the sclerosing forms are on the further studies. Prevention is a very important topic which you should ensure for patients. Um, and as the nutritional assessment, physical exercises, which are powerful tools in handling patients with chronic venous disorders. Um, So how to reduce the oxidative stress, inflammation, and so that we can decrease the healthcare cost and productivity. And
What are the causes of recurrence of pollen stripping?
surgical stripping, sir.
Yeah. What is the incidence of recurrence?
About 20%, sir.
What the exact percentage? Ravan, what are the causes?
Sir, most commonly is inadequately done stripping only, leaving out the important tributaries on top.
Yeah.
Um, that is the most common cause, sir, and that neo-revascularization is always there at the
What about
junction.
the posterior arch vein?
Yes, sir. In the below knee segment, posterior arch vein is also a very common reason, sir. That's why many a times, sir, even now with open surgery also, for the lower part of the thing, I give off little sclero, sir, so that this problem doesn't come.
Sameer, how many more slides?
At least 20, around
Yeah.
15 to or
What is there,
15
man? 20?
I think it has to be done in next class, sir. What do you say, Shravan, sir? It's already 10:15.
Yes, sir. Yes, sir.
So I think it's quite late already.
What are the topics left? Venous ulcer and
DVT,
DVT, yeah?
sir. DVT.
DVT also is got, sir.
Yeah, DBT is again a separate topic. I think we'll keep it for next class, both of these.
Yes, sir. I think that's a fair thing because DVT is more elaborate we have to discuss rather than venous ulcer only 1-2 slides. After the
Correct, correct.
DVT we have to see.
Yeah,
And put a small video of
okay.
this endovascular
Laser,
Yes, sir.
next class you put
laser
it up,
and
Sameer.
sclerotherapy.
Yes, sir. Yes, sir. Yes, sir.
And okay, comments?
Sir, one
Nikita,
question I had.
Praveen. Yeah, ask.
Sir, intraoperatively, do we go for adjunct therapies like on the table, sir? Like if you're doing multiple stabs for perforators and then tortuous veins, without giving multiple stabs, can we go for adjunct therapies on the table itself?
Meaning?
What do you mean by adjunct therapies?
Sir, like we have
Like
decided for
endovascular.
surgical stripping, but then we see there are multiple this reticular veins and which will
Clots.
require
That is what Shravan sir told, no? He does sclerotherapy when there are situations like that.
on table. This,
See, the way
Not
I
on table at the same setting and
same sitting, correct. Same sitting.
okay.
Yes, sir. You are telling something.
So, yes,
you can either do stab
mostly
incision and excise or do sclerotherapy or endovascular therapy.
yes. So many patients were combining all three also, sir, nowadays. Especially
Yeah.
patients are coming with big bunches, sir. Thigh
Cross
segment
varicose veins,
laser.
single procedure will not help.
Yes, sir. Yes, sir. Upper thigh segment laser, upper leg phlebectomy, and gaiter area sclero. Many patients are combining all three together, sir.
Sameer?
Dr. Samir, that answers your question.
Yes, sir. Thank you.
Anybody else has any questions? Okay, no questions,
No, sir.
comments. Yeah, Nikita. Final comments.
Sir, his presentation is relatively better, sir, but most of the slides he did not put the references, and most of the indications and contraindications he missed out.
Yes.
But
Okay.
it's relatively better, sir.
Yeah, presentation is better, but you don't know what you have put it up on the slide, Sameer. That is the basic etiquette of any presentation. Okay, and Praveen?
Which year is?
Second year now.
Did you show it to the registrar before presenting?
Sameer,
Yes, sir. Yes. Sir,
answer.
Shravan sir only had seen.
No, sir, he didn't show.
Shravan sir had.
Sir, he showed it to me. I already had given some comments
Changes.
on how to add on.
Mm.
He's done most of it. I would say 80-90% of my suggestions
Presentation
is
is
taken in.
presentation is good, but
Sameer, you have shown it to Shravan sir, correct. What you have put it up in the slide is correct. But before that, you should be knowing what you have put it up. The
which is
problem is you
important,
didn't
which
know.
is not important, you should know. That's all.
The problem is you didn't know. Like indications of sclerotherapy, you have just put it up blindly. Like that thing where you have said the agents for sclerotherapy is liquid and whatever foam sclerotherapy. It is not agent. So those are the types. So you should be knowing the basics. So for that you should have read it properly. I think that is where you have missed it properly. Probably you're not prepared for the presentation in detail. Anyways, but it is better than earlier, definitely. And what is the problem with you in showing it to registrars?
Fight,
This
he had a fight with
this
her.
is the this is the repeated complaints. Whenever you
All
have a
PGs, sir.
Allah, you especially Sameer, whenever he has a presentation, he'll be inadequately prepared. He doesn't take their help. I don't know what is the issue. It doesn't show it to them also properly. Anyways, Nitya, Sanya,
Sir, yes, I would go with, as Nikita says, better presentation, sir, but still he needs to improve, sir.
work hard. Yeah. Okay. Sanya,
Same thing, sir. He should improve in his presentation.
Tani has become consultant. Huh?
No, sir.
second sir.
A good presentation. Huh? Small mistakes, no problem. Very good. Just put the
Shravan, sir?
videos up next class.
Yes, sir.
Shravan, sir? Final.
Yes, sir. Compared to last time, definitely he's put in a lot of effort, sir. And
Yeah.
couple of times he came and discussed with me also. He sent the PPT over WhatsApp also. Definitely he's put in the effort more compared to last time, no doubt.
Yeah. Okay. Sameer, next class, you have to work hard even more and be prepared.
Yes, sir.
Okay. So, if no more questions, I think we will conclude. Huh? Thank you, sir.
Sure, sir.
Thank you very much. Good night.
Thank you, Shrikant sir, Narendra sir.
Thank you. Thank you.
Good night, sir.
Thank you, sir. Good night.